Hi, everyone. So we are H-STAT, Health Students Taking Action Together. I'm Serbi, Sharon, Avni, Rebecca, and Alice, who's not on the call. We're all on the board of H-STAT. We're an organization focused on advocacy and education around policy issues, if you haven't heard of us before. And this is part of our series that we are, a speaker series that we've launched this year called Health Professionals as Policymakers. So we're really excited to have Dr. Fakorede here with us today to be discussing health equity, the Black American amputation epidemic, and maybe give us some pointers on how we can pursue policy-oriented careers in the future. So just to begin, a quick roadmap for today. We will start with just an introduction, 10 or 15 minutes by Dr. Fakorede about his work. Then Rebecca Hong and I will moderate a Q&A session for about 30 minutes. And then at the end, we'll have open Q&A. You're welcome to put questions in the Zoom chat as we're going, or you can message us directly and we can read them out at the end. Or if you'd like, you can tell us and we'll call on you and you can just unmute once the Q&A begins at the end, and you can ask your question directly. So an introduction, we have Dr. Fakorede here with us today. He's a practicing cardiologist. He completed his training in internal medicine at New York Presbyterian Cornell Hospital, and he specializes in preventative cardiovascular management. He has advanced technical skills in preventing amputations and utilizes advanced minimally invasive techniques in treating patients with peripheral arterial disease. In 2015, Dr. Fakorede started Cardiovascular Solutions of Central Mississippi with a mission to educate and provide access to high quality care for all. He is currently the only cardiologist in Bolivar County, Mississippi. He serves as co-chair of the Peripheral Arterial Disease Initiative for the Association of Black Cardiologists. And in 2018, as part of a congressional delegation, he testified at the Capitol regarding the epidemic of peripheral arterial disease and spearheaded a campaign, a Sprint to Zero amputation campaign. Dr. Fakorede has established partnerships with lawmakers, the community, with faith-based stakeholders to facilitate cardiovascular education and highlight social determinants of health, improve access to quality care, and build trust in the community that he works in. These preventative initiatives, the aggressive screening, and quality intervention strategies have led to amputation rates decreasing by over 80% over a 3-year period in the Mississippi Delta where he works. So we're so excited to have a leading national voice in health equity here with us today. And Dr. Fakorede, I'll kind of give you the space to introduce yourself.
Well, Serbi and teammates, thank you very much for that kind and warm introduction. And thank you for the pipeline of what I call our, the greatest healthcare or health educational pipeline in the world. It's an honor to be here. I want to start by acknowledging not only your organization, but also your mentors who you look up to, who fight this fight every day to bridge the gap in health inequities that plague our healthcare system. So with that said, I'm just going to get to it and share my screen. I hope everyone can see it. Let's talk about how I got here and who I am and my why in terms of life, right? All right. So peripheral arterial disease is an atherosclerotic burden, but also it's a disease that we need to fear. Why do we need to fear PAD? Because it's a progressive disease. It's asymptomatic in presentation, similar to cancer. It's slow, it's progressive, and it's deadly with a high mortality and morbidity rate, leading to a lot of disabilities and also a lot of deaths. And we need to identify who these patients are and identify how they cause other co-prevalent causes of cardiovascular disease, which is the #1 killer. Heart Health Month is this month. So we all know that the number one killer is cardiovascular disease. One in three women will die of cardiovascular disease, and every 37 seconds, someone will die from a cardiovascular event. It is very prevalent. A lot of people don't know this. There are about 20 million people that suffer from peripheral arterial disease, actually more than coronary heart disease, which is about 16 million, and cancer. Diabetes and obesity are biggest unique challenges if you look at the diabetes epidemic in our country. And so for each and every one of you on this call today, you need to know about diabetes and obesity, especially the rates, the alarming rates, and how they lead to both a clinical, economical, and human impact. For me here in Mississippi, how I ended up here was because I looked at the Black Census Scope of America in terms of where are the largest population of African Americans in the country. Mississippi actually has 40% African American representation, the highest of any other state. But what was sad in this, statistic, and you see this in all these medical seminars or societal meetings that you attend, you'll see that the amputation rates in the South are also the highest. But what's tragic is also those similar areas have the lowest number of procedures that are performed to save those limbs, called revascularization, meaning to restore blood circulation to these patients. So there's regional variability in care. And when I came to Mississippi in 2015, there was a 54-year-old mechanic who was basically had diabetes and stage-renal disease on hemodialysis, and made an income of about $35,000 a year, had 3 kids, came in with just a wound in his lower extremities that needed a revascularization procedure, which I performed. And it was success. At the end, we had 2 good blood vessels to his foot. And I left town on a Friday morning, and I came back Tuesday, and that leg was amputated by a surgeon. So this occurred while I was in that hospital. So imagine what happens when a physician like myself is not in that hospital. You can only imagine the impact. And the US Surgeon General even posted on, why do we have a healthcare system where we spend $800 million a year on amputations, knowing that we could spend exponentially more to prevent these amputations by addressing their risk factors? And that's what we highlighted in the Black American Amputation Epidemic. It's a story about how I ended up here in the Delta, and it basically highlights the plight of a couple of my patients, addresses not only what I call the amputation lottery of America, which we'll talk about in our discussion, but also why we have policies that are in place that don't promote limb preserving strategies, why we don't incentivize young physicians in training or out of training to come and serve rural places such as here in the Delta, and also why we have lack of representation in the pipeline where we can, regain the trust of the community, reach these patients where they are, try and treat their risk factors, and have a population screening approach to these patients. And the U.S. Preventive Service Task Force is basically a body that basically, has an extensive portfolio where they determine what services of health all Americans should receive based on evidence-based. And Medicaid or Medicare, CMS, will give basically a grade. And that grade is either an A, B, C, or an I rating. And an I rating is where we have insufficient evidence regarding the benefits versus harms of providing that service. These patients that you all see on this screen are patients who showed up either to my clinic or to the hospital, and where I just told them to take off their socks. And this is what you see. And these patients predominantly are minorities. And what we showed here at Bolivar County is that we could institute a holistic method to approaching these patients, screen them, treat them, and reduce amputation rates, which we did by 88%, as you mentioned in your introduction. But we need to highlight, why is this disproportionately higher in African Americans and minorities, and just in general, women included? There remains a significant disparity when you look at African Americans, Hispanics, and Native Americans versus their non-Hispanic counterparts. And here's just an idea. I mean, it's about 2 to 4-fold difference if you across the board. And these have been documented in articles. I'm not creating this out of the air, right? They're articles and abstracts that are well designed and that have looked at different populations, predominantly in the minority population. But we have to know that there's an impact when it comes to diseases that exacerbate these outcomes. Diabetes being one of the two, right? We talked about the diabetes epidemic. Well, diabetes causes more severe blockages called ischemia. More patients present with ulcers initially, and they develop what we call critical limb ischemia, which is known as CLI. It's an equivalent of a leg attack or heart attack, right? And it increases your risk of amputation and cost, and they die younger. That mortality, 80% are dead within 5 years once you get amputated. So why don't we screen for at-risk patients? What does the US Preventive Service Task Force that was founded by Congress in 1984 say about this? Well, their statement is that PAD and the prevalence is disproportionately higher among racial and ethnic and low socioeconomic populations. And they gave it still an I statement, in spite of them, affirming that this will discourage testing and perpetuate disparities in treatment and in outcome. These are their words, not mine. And they recognize these well-established disparities in care. However, screening in these patients are currently lacking. I repeat, evidence-based reports of screening and treatment in these patients are currently lacking. Therefore, we cannot determine the benefits of screening these patients. Now, for anyone who's listening, I just gave you kind of an introduction and papers showing how African Americans disproportionately fare worse. And these comments were sickening. And these comments still sicken my stomach to this day, because it's just unacceptable. And so we can screen for any of you over 18, I hope, but we can screen each and every one of you for alcoholism based on the USPSTF. We can screen each and every one of you for hepatitis C, but we cannot screen you if you're at risk for PAD if you have those risk factors for peripheral arterial disease. And so, you get mad. What do you do when you get upset? You take action. There's something called empathy and there's something called compassion. And the difference is basically compassion is what you do with the action you take on top of the empathy. And so realizing that for some, it's conservative to chop someone's leg, but for others, it's aggressive. And knowing that these patients have an extensive healthcare and financial burden that can tally up to $500,000 per lifetime, knowing that they only bring in about $30,000 to $50,000 in that time period, you realize that it takes a team, but also you need to speak truth to power on this topic. And so I took a patient to the Hill. I went to Congressman Payne Jr.'s office. He's a congressman from New Jersey. And this was a bipartisan effort, a sprint to reduce amputations, where we used the VA model, which basically showed that screening these patients and using a multidisciplinary team approach can reduce amputations, and showing them what we did here in Bolivar County, but also taking this patient who was the first female postmaster in this county to highlight basically that she lost her limb because her diabetes was not screened early. And she lost it, basically taking her out of the workforce and causing significant burdens and pains to her family. And a couple of years after losing her first leg, she lost her second leg. 5 years after she lost that second leg, which was last year, she died. She died, unfortunately. But she did go to the Hill, and it led to the formation of a peripheral arterial disease caucus, and eventually Amputation Reduction and Compassion Act. And the PAD legislation, it was introduced last year with the main provisions. One, we need to coordinate and educate the masses about peripheral arterial disease. It has a low awareness state. Only about 1 in 4 people, adults, have ever heard of PAD. Establish coverage for all those who are at risk, and then let us develop a plan where non-emergent amputations need to be, assessed first with arterial testing and treated before they get amputated. And then we develop quality measures for that. So morality cannot be legislated, but behavior can be regulated. And this came from the civil rights era, when Martin Luther King was sick and tired of people lynching folks and the poverty inequity. So you might not love me, but you will not lynch me. Well, in this case, you might not love me or like me, but you shouldn't chop off my leg. That's the bottom line. So put your passion and purpose together, and let's bring about some equity in terms of addressing some of the disparities that have plagued our health system. Because if not treated, it's going to lead to more death. And of all forms of inequality, injustice in healthcare is the most shocking and inhumane. So let's bring some humanization back to what we do and raise the moral consciousness of Americans so that we can stop this intergenerational scar. Thank you very much.
Thanks, Dr. Fakorede. It was a great introduction. So I guess to kick off we're going to have our moderated Q&A right now. Surbi and I are just going to have a conversation. It'll be casual. And again, you guys, as questions come up, please feel free to type them into the chat. We'll collect them, or you can wait till the open Q&A at the end of the session to just speak up and ask your questions. So I guess my first question for you is just, you've done so much. You're a doctor, you serve a community, you're an advocate, you're going on the Hill, sponsoring legislation. How did you get to this point, and what was your aha moment? The ProPublica article talks about you just picking up out of Tennessee and just moving. Mm-hmm. Where did you get that inspiration from?
Well, one, born to two beautiful parents who, were born and raised actually in Nigeria, West Africa, and understanding what it's like to have, parents who instilled in you at a young age that, you speak up when you see something that's wrong, and two, you advocate for those who lack a megaphone or who lack a voice. And when I moved to New Jersey during my teenage years, and I went to high school and college and medical school, I became active in my community in New Brunswick, New Jersey, and in Camden, New Jersey, tough neighborhoods. And you can understand that, what these patients need and the population sometimes needs is to have their social determinants or health metrics addressed. But it's easy for us that wear academic hats or, white coats, I would say, where we walk into a room and we tend to lose the sense of what the purpose is, right? Medicine encompasses the power of mankind to do good, to heal, but also to be humanistic. So I need to not only sympathize and empathize, but compassion. Why are you losing your limbs? And why are you having more heart attacks than someone else? Why are you on dialysis more than someone else? Well, these are things that race through your head. And we do research, we believe in the science. But then what do we do about that when we see a health disparity? Well, I'm an African-American cardiologist and interventional and endovascular specialist. There's only less than 1% of people who look like me in medicine in the country. And we have this amputation epidemic here in Mississippi. So the aha moment was more so, what legacy fight can I initiate where I can come here unrecruited and people thinking I'm crazy, and to come and start off a practice, which I knew nothing on how to start. The first 6 months of billing was just off. I did not even bill one patient. Because when I taught this in medical school, how do you start a practice? None of you, we don't know that, right? We just know how to practice medicine. But one thing I found was that, when you believe in something so strong and your purpose is just, no obstacles can stand in your way. And I came here and I saw how fast and how quickly these patients were losing their limbs and how preventable. 90% of these amputations were preventable. So that was what spawned the interest in research and seeing what are policies in place to prevent these amputations. Well, there are really none, because all the documents don't advocate for screening by primary care physicians, who are the frontline physicians that most of these patients see in rural places. There's a lack of specialists in these areas. I told you about diabetes in Mississippi, but we only have less than 10 endocrinologists in the whole state. Less than 10. It's scary. So primary care docs are their advocates and their frontline and their quarterbacks, but we need specialty care. So what are we doing in medicine to recruit doctors here to rural areas rather than send them out to Doctors Without Borders? So I came here and I decided to do good work, but publicize it. Publicize an atrocity whenever you see one, or injustice whenever you see one. That's what worked in the civil rights era. That formed a coalition. Both black and brown people got together, white people got together, and they started that civil rights movement and march. That's what my intentions were, and that's what I did.
So following up on that, who would you say, what kind of connections and allies have you acquired since going to Bolivar County, and who do you feel like is the what is the core piece of the puzzle to build trust in this community and really
Right.
advocate for your patients?
That's a great question. You know, the key is one, to form community navigators wherever you go. What does that mean? When you go to any community, and especially if that community either reflects your culture or maybe not reflect your culture. The one thing you have to know is, one, you have to understand the strengths and the weaknesses of that community. And in this predominantly, African American community, the faith-based systems are, and the faith-based organizations are the strengths of that community. The women in these organizations are the pillars, especially when it comes to healthcare. They're the healthcare drivers. They're the ones who force the guys to go and get their health screenings or to get their health checks. And so that's kind of what I use by taking my weekends off to go and speak to them and give them just a 10-minute presentation at either church event, because you have to understand now the culture in the South, right? We have Friday night lights. I'm sure in Georgia this pertains. Friday night lights, so that's high school football for those who don't know. That's gone. Saturday, if you tell people to come to a health fair, it's not going to happen. Why? People are out either shopping for events, and there's Saturday football too. There's travel ball. There's just a lot of things that happen on Saturdays. And then Sunday, guess where everyone goes to? Some church. All stakeholders are in church on Sundays at some form. This is the pre-pandemic, right? And so that's what I decided to do. Just find a forum where you can garner the attention of all stakeholders. And so the faith-based organizations have been very powerful in spreading the word, and that's a direct consumer approach. You bypass the physicians that some are well-intentioned, and some might have some biases against your cause. And so going straight to the patients and telling them, hey, seek a second opinion before you get an amputation. Get your diabetes screened, get your A1C levels low, get your blood pressure controlled, get your cholesterol checked, get your stress test done, get your ultrasounds done. Those are things that no one actually comes to their homes to tell them, right? So that's what I did. It's a direct to consumer approach. And that's been the best ally, I think, in all of this.
When you first started, though, you first started pulling up with your presentations and stuff, like, how was that? How were you received initially?
Eyes wide open. Like, how to explain how an amputee we get from a normal blood vessel, excuse me, I'm just going to reach how we get from, and I use this sometimes, how we get from a clean artery to plaque buildup, right? If you all go out and ask any of your patients, how does that happen? 95% of them don't know. Not only that, social determinants of health is important, because when you look at that whole board of spectrum, and all of you must memorize that chart, what are social determinants of health? Income inequity, right? So wealth inequity. Can they afford them the medicines or their medical bills, right? To educational inequity. Do they understand from a literacy standpoint what you say? What is PAD? They're visual, so you have to speak at their level and use graphics if you need to. Food deserts, access to quality food. Don't just say, hey, diet and exercise. What's the physical neighborhood? Do they have gyms? Do they have a walking trail around? Are the neighborhoods safe? Do they have transportation? A big issue in rural America where they have to travel 2 hours just to get a stress test or to see a specialist. And then, we look at the social context of not only the stressors in the community, but biases, discrimination is real. And then the health piece is the last piece that we all always focus on. Access to, to coverage, access to quality care, provider availability, and competencies. Well, 80% of the problem is actually not the health component. That's 20% of health disparities. 80% is everything else I mentioned. So that is, education is very important, and making sure that they can be informed to be transformed.
So you mentioned all of these different ways in which the US healthcare system, but also society is failing patients. Is there a particular patient story that stands out in your mind that would illustrate how the US has failed the patients of Bolivar County?
Right. I mean, the two patients that I highlight are one, but I tell you, one is a guy who's a mechanic who had a fourth grade level education, who I treated his blockage, and I left town for 3 days, and he got his legs amputated. You know what that means for that man? That means 80%. He has an 80% chance of being dead 5 years from that amputation. Two, the cost to take care of him now goes from him making $30,000 a year as a mechanic to being out of the workforce. Prosthesis, can he afford that? If he's a Medicaid recipient, it's not even covered here in the state. 90% of these patients will have chronic pain. Another 30% will have the other leg amputated within a year, and most of them will have revisions of their first amputation stump 60% of the time. The cost of the family to take time off of work to bring that patient, the cost to put a ramp in his house, the cost to buy him a new car that is accessible or to fit his car. Those are things that we need to think about. And so every patient is unique. Mrs. Campbell, which was that patient that died last year, her best friend was also a patient of mine who we saw at a population screening event, who had a stroke many years ago. And people didn't correlate the fact that plaque buildup occurs not only in your legs, but it occurs in your heart attacks, right? Coronary disease, it occurs in your neck, carotid artery disease. She had this in her neck and in her heart, but they missed the legs. And, she was wheelchair bound for about 5 years. I brought her to my lab. We saw that she had a significant blockage. We opened it up in a superficial femoral artery that was 100% occluded. And she stood up in 2 weeks, was able to stand up from a wheelchair. So they're just ways that we need to take a holistic approach in identifying, risk stratifying, but also in making sure that we know the evils of amputation once an amputee loses a limb, because they're potentially going to lose their lives as well.
So something that you mentioned earlier when you were presenting was the idea of an amputation lottery. Could you expand on that and why there is such an epidemic?
Sure. Well, it's right in step with social determinants of health. An amputation lottery basically is, what are the factors that determine who gets amputated in America? One, your race. If you're a minority, and I've mentioned that, and I showed you the slides, it's African American, Native Americans, Hispanics, and women more than men. We're seeing more and more of that now. We're seeing region, where you live. If you live in the Southern Belt, if you live in areas that are, even if it's urban area, but more populated with minorities, you're more likely to have areas where they provide lower revascularizations to those minorities compared to their counterparts. And then the hospital volume of limb preserving procedures that are performed, meaning that who perform amputations and who outweighs who, right? So if those surgeons just amputate all the time, and there are 10 of them, and you have one Fakorede, guess what? Those numbers are not going to be in my favor. So this is where it's beyond just me trying to do good work. That's where policy comes to play, right? As I've said, policy is not to change your hearts, but to restrain the heartless. So there are physicians who might not know that what they're doing is heartless, but we know that what they're doing is heartless, and that's what we need to stop.
So we definitely want to address the policy piece and talk a little bit more about these systemic barriers, but speaking specifically about those physicians, are there particular actions that individuals are making in order to drive this amputation lottery?
In terms of what what we as a society actually has failed is that when you look at social determinants of health, most people talk about, and most people flip it and say socioeconomic status, right? So if I were to just run quickly and tell everyone write one thing down about what socioeconomic status is, what do we write? Dollar sign, wealth, or money, right? So how much money you have, how much money you have to do things, right? That's what we'll all write. Well, maybe we need to add this metric. Whenever we're talking about the population health, or when we talk about, looking at standards across, like how well is a community doing, the health metric should be number one, actually, not wealth or not economics. Because without health, right, there'll be no wealth. You can't have a pipeline of people in your line of productivity workforce to work, right? For those people who are like saying, "Hey, listen, Medicaid, it's a way we need to get more people into the workforce." Well, maybe if we start treating patients where they don't end up on dialysis or end up amputations or having heart attacks where they can't work, maybe that will drive the workforce, right? People will have the ability to go out and work. Or individuals, maybe we need to, start looking at habits. What are our dietary habits? What are things that we can do with our kids? They do it in other states. They tax sugar at a different rate. Maybe, we need to address that because sugar is the new tobacco. Diabetes is a big problem. What are we doing to address other factors that are unique health drivers like obesity as well? What are we doing to address that and address it not only from a macro level, meaning trainees, but also in other aspects of life where kids in schools, in vocational training, and in other allied health professions as well. That's something that creates some kind of interdisciplinary meet point. And when we have that juncture, we can then, come up with policy that covers all. And that's kind of what we're trying to achieve here.
So speaking of policy, what legislation right now are you kind of focusing on aside from ARC? Do you have federal and state things going on, or are you focusing mostly on federal legislation?
Well, that's good. That's a good question because right now I'm focused on federal, the Amputation Reduction and Compassion Act, because that's something that we've been working on since 2018. So it just tells you how policy works, and it just got introduced. It hasn't been passed, right? It has to get actually reintroduced, and there has to be multi-level steps. It's a bipartisan effort, but politics is just what it is. Right now it's just it's not positive, especially when you're trying to drive a force where you think, independent of where you stand in politics, if you're Democrat, Republican, or if you're in the middle, independent. This is an economic issue, all right? Even if you take out the humanistic issue, like, people should just not lose their limbs. But let's just talk economics. We have a problem that costs our healthcare system billions of dollars, 90% of which can be prevented. 75% of the cost is paid for by taxpayers, 75%. So any of you who've had a job or who currently has a job and has paid taxes, that's what you're paying for. So if I told you that we have this problem that we all can save tons of billions of dollars and use that towards maybe preventative strategies or other things, it makes sense, right? Economically, regardless of where you can sell that to any constituent and they'll vote for you. So that's kind of the hat I wear in terms of, when I speak to policymakers versus when I speak to a team like yours. My lens in terms of how I approach it has to be different. Sometimes I focus more on economics and sometimes I focus more on the humanistic and the clinical aspects. But, other bills or other issues we have to look at is the recruitment and retention of specialty care in rural areas. If you're not hospital employed, how do we incentivize these patients to pay off their loans? Right now, we don't have a good system to do so. Two, if we were to come to that rural area and we have hospitals that, fight you to do certain types of procedures versus not, and there's, these things called certificate of need that you need, well, it puts you at a disadvantage if you're an outpatient driven doc where you want to just, advocate preventative care. If you're not affiliated with a hospital, you're seen as basically your efforts don't count or don't matter because you're not under that umbrella. That shouldn't be the case, So those measures need to be in place, and those are fights you fight on the local level. And then the expansion of Medicaid is an issue. Mississippi has 3.3 million in our population, about 500,000 of whom are uninsured, and it did not take the American Care Act expansion years ago. So these patients are left uninsured. So an uninsured patient leads to what? It leads to more acute care in your emergency rooms because these patients don't have preventative care or primary care physicians and wait till their legs turn black or brown, or a dog eats the flesh off their skin, true story, before they show up to an emergency room. That is unacceptable.
So you mentioned a lot of different pieces of policy or a lot of different contributors to the problem. And the first piece that you talked about was the lack of specialty care in rural areas, which is partly driven by, student loan debt forgiveness programs. So I guess if you could expand a little bit more on the problem, how you perceive the problem, how it affects Bolivar County where you practice, and then maybe potential remedies that you could see to encourage more specialty care in rural areas.
Right. That's a good question. When I was first recruited to Tennessee, I was recruited to a hospital. And so there was a physician recruitment agreement where, my loans were partially forgiven. And I decided to leave a year later. And, those contracts are kind of bounded where they'll keep you for multiple years. But I wanted to come here where they had no specialist in this region, and where I felt like my skill set will be better utilized. And when I came here, I just took on credentialing at a local hospital. And, I was self-employed. I started my practice. And then I looked into loan forgiveness programs and come to find out, unless you are, primary care or you're a dentist, pediatrician, psychiatry, I think that's it. You do get some form of loan forgiveness in terms of rural healthcare assistance, but that's it. So as a cardiologist, as soon as I landed, I was seen as, oh, you're going to be fine. You're a cardiologist. Okay, I need to start a practice. I need to hire staff. I need to get the ball rolling in terms of, ancillary work. And that takes time, but that takes resources. You have debt, some people have families that they have to take care of. And so it'll be good to be able to say, hey, listen, doc, we know you're coming here to this rural place. Let's have a program where if you can prove that you can decrease amputation or heart attack rates by X percentage within a certain year, or decrease, if you're an endocrinologist and you decrease A1Cs by, a certain percentage and give them certain metrics, and you review those health metrics and incentivize that, I think that's a win. More people will like that challenge, actually. And two, I, as a solo practicing physician, can now recruit a partner or two to come and join me. But if that doesn't exist, it's very hard to recruit those specialties, right, to your region, because they're going to face the same insurmountable challenges that you once did. So that's this whole, if you're not hospital affiliated or hospital recruited, you're doomed. That approach is not the way to go. And that in itself is a bias. And we need to address that, both on a national, a federal level, but also on the state level. And there's some cities too who work towards, working with, I think, physicians organizations and some nonprofits that can help physicians. But that was not the case for me. And I think that we need to have this discussion on a national stage while we address social determinants of health.
Could you maybe also give, I would imagine that part of the barrier of recruitment also is that maybe rural medicine is not necessarily at the top of everybody's mind when they're going into medical school, and maybe even specialty, because people have an expectation you're going to make a lot of money when you go into a specialty.
Right.
Can you kind of give us a pitch of why going into rural medicine is the right career path?
Well, for those who think it's, so right now, as I talk to you, I'm a physician with, um, I have tons of employees now, and we have close to about 9,000, 10,000 patients. So that is because I came to an area where there was a need. I came to an epicenter of cardiovascular disease. You have to understand the growing trends for those who are interested in cardiology, right? So what's the growing trend? Well, we have more chronic diseases, right? We have an increased aging population, all right? The fastest growing population in America are all octogenarians. You know what that means? You're gonna be seeing a lot of this in all your systems, a lot of other issues, all right? Because as you grow older, you build up plaque. And then look at the average workforce, like the average age of the workforce of cardiologists. They're probably in their mid 50s. And no offense to anyone in their 50s who's watching this, but that is an aging workforce. So by the time, that's the median age of a cardiologist. So by the time they get to 70, most of them are checking out. So in 15 years, 10, 15 years, they're out. And so, and then you have states that have the lowest number of physicians per capita, like Mississippi, where you come here and as a cardiologist, you see, health despair, but it's also an opportunity. It's an opportunity for you to build something that is bigger than, what you can imagine, and do it in such a way that is just right, and do it with the right cause, and speak on behalf and be a voice for the voiceless while doing it. Publish your data. Um, and that brings a lot of attention, both local, regional, and national attention to you. And that was unsolicited. That's just doing good work in rural times. I always tell people despair is, a poor chisel to carve out tomorrow's justice. And that's the case here. When I came here, I saw despair. For anyone who's been to rural America or the Delta, there are places where you see just despair, but also it's an opportunity for you to change that trajectory for generations to come. And that's what I see in providing care here in rural America.
Thanks. And kind of just shifting to a very different direction, but obviously right now we have a pandemic, COVID-19. How has that been affecting your patients' access to care and prevention services?
Well, COVID-19 has only unblinded, health disparities and the fissures in our healthcare system, right? And it's also led to exposures of the intergenerational dehumanization of a few. So when you look at amputation rates, for instance, it's um, COVID-19 is an endothelial disease. This disease, it causes endothelial dysfunction. People are more prothrombotic and more atherothrombotic, and so you're having embolic events, more DVTs, PEs, more amputation rates, and you're seeing patients who have those risk factors for cardiovascular disease who are disproportionately affected, right? And have worse outcomes. But also, most of them are poor, are in rural states because of lack of access. Transportation is an issue, right? Physical environment. I told you about housing. So if you understand the history of housing and redlining in this country, a lot of minority communities are, they're intergenerational households. So when one person gets affected, guess what? Everyone gets affected, and it eradicates. A little breaking news for those who are, big on this telehealth, telemedicine as just the only cure. It's been great in certain areas, but what telehealth and telemedicine has also done, it's exposed some of the disparities in access to quality care. You know why? Because 70 to 80% of my patients do not have internet bandwidth, and they don't have a smartphone. So how do we take care of that issue? Or they have issues with their circulation in their legs and feet that I cannot triage by just looking at it from a distance an hour and a half away. If someone's leg is turning blue or black, guess what? They're having a heart attack, a leg attack, right? So if someone's having a heart attack, you don't just say, hey, listen, telemedicine, take an aspirin, I'll see you in a week. It doesn't work that way. Time is muscle. They need to rush and come and see you. Well, that's a risk not only to the patient coming into my facility, but for me and my employees as well. And so that has been tough. It's been very tough. And it's been tough to see how, how a whole community just gets upended, especially with the exacerbation and the annihilation that this virus has caused, not only locally, but nationally. So that's why I'm a big proponent of folks getting vaccinated. I'm out there telling my constituents to get vaccinated. I show my pictures. I happen to spend a couple of days, for those of you looking at me as this healthy, 39-year-old, I was in ICU for 4 nights with COVID-19 in November. Yeah, it got real. I couldn't breathe. So why? Because I see a lot of patients every day. That's just a risk. It's not because I'm in rural America. It can happen to any physician, any frontline nurse, or any other respiratory therapist or any essential worker that's out there. So it's just, we have to get over this hump, and herd immunity is something that we need to strive for by all getting vaccinated and sharing that and breaking that barrier. There's a barrier of mistrust that is justified in minority communities, but also the signs recently and the fact that, we've had more people represented in clinical trials to date in this vaccination trial than any other cardiovascular trial, to be honest, in percentage points, historically. That means a lot. So that's where you try and educate and inform and hopefully, lead the masses towards the right decision, towards vaccinations.
So Dr. Fakorede, we have one more question for you before we'll open it up to everyone else.
Sure.
These problems that you've mentioned, they're not easy. Their solutions are not easy as well. What motivates you to keep going? How do you maintain the motivation to keep going when you're tackling this systemic issue?
Yeah. So for those of you who know the history of the civil rights era, I mean, my office is about 30 minutes south of where Emmett Till was murdered. Emmett Till, young kid from Chicago, came to Mississippi to visit his uncle, went to a grocery store, and the wife of the grocery store owner apparently said that this young black kid whistled at her. She was a white lady. And later on that evening, the owner of the store and his brother went to that uncle's house and dragged him out, brutally beat him up and murdered him and dumped his body in the Tallahatchie River. His mother, May Till, brought his body back to Chicago on a train, and as soon as it arrived in Chicago, she opened it up for the world to see. And it was on Jet magazine, it was everywhere, and that was with the impetus. Not Rosa, people talk about the bus and Rosa Parks, but actually Emmett Till's story was the impetus for the civil rights movement to gain that momentum it needed, because it publicly showed the atrocity that was going on. So whenever I get down or whenever I think, hey, listen, this is challenging, or I'm facing challenges locally or regionally or nationally, I visit that site, because when you think your battle was bad, right, you see what people had to endure so that I could be able to stand where I am today. That's what motivates me. There is an injustice in healthcare, and it's not just PD and the Black amputation epidemic is just one silo. For anyone who's interested in cancer or oncology, I'm sure there's stories, right? For anyone who's interested in OB gynecology, I'm sure there's stories. For gynecological future residents, the first, the first surgery that was performed were on slaves without anesthesia. And that turned into a whole, surgical procedure in gynecology. Well, what's happening now? That's something you look at and you track and you say, historically, what are data points? The underrepresentation of minorities and women in clinical trials is a big problem. Medication affordability of medication and how pharmaceutical industries have taken advantage of that process. It's a big problem. So addressing social determinants of health is huge. But for me, the motivation is just knowing the history and understanding those who came before me that gave me the platform where I can be an advocate and I can speak truth to power on a topic that most people cannot relate to unless they come here and live and see and become compassionate towards finding a solution.
Well, thank you so much for being here today. I'm going to open it up to everyone else for questions. We did have a question submitted through our RSVP form, so we'll start with that one. Are there ways of getting involved in health equity as a resident that are compatible with the resident schedule?
Yes, there are. I mean, I know it's challenging, but as a for me, I got involved in SNMA, which is the Student National Medical Association, and National Medical Association early on in my career, and so there are different organizations that are involved, but also mentorship wise, what you do for those interested in policy. If you have, for instance, budding cardiologists who are interested in cardiology, the Association of Black Cardiology has a huge track and pipeline where, and for anyone on this call, you don't have to look like me to join, you can join. It's all about, representing minorities in general, but also it's all about making sure that we achieve, equity when it comes to trying to bridge the gap in health disparities here in this country. Two, it's also making sure you have good mentorship. Mentorship is very important. And for me, that was huge. And your mentor does not necessarily have to be a cardiologist or someone who's doing policy in cardiology. Your mentor can be just someone who understands how to weave you in and out of that policy realm, right? And so try and find someone who is not necessarily in your field, but someone who's a policy wonk or policy advocate. And lastly, it's to believe, but believe, have a mission. It has to be purpose driven, but not just sell yourself on, oh, I empathize or sympathize, but I'm compassionate towards this because I want to act on it, in addition to empathizing with whatever that cause may be.
So our next question is going to be by Roshan. You can just unmute yourself and ask.
Yeah, sure. First, I just want to say thank you so much, Dr. Fakorede. Your words were very, very inspiring. And, this is something that I personally did not know much about. And I think, the work that you're doing is absolutely incredible.
Thank you.
So my question is, I know we've sort of been talking a lot about policy and changing, some of the systemic factors. I was wondering, what do you think, though, is the most important thing physicians sort of on an individual level can do to sort of help address this issue?
Yeah, that's a great question. One, we need to take off everyone's socks that comes in that has certain risk factors for peripheral arterial disease. Take your socks off. And you know what? Get comfortable touching people's feet. That's it. Non-cardiologists, primary care, and who are those at risk? So let's go over it. Anyone over the age of 50 who's been a diabetic or who has hypertension. So between 50 and 69, if you've had diabetes or one of those risk factors, you're a nicotine user, or if you're under 50 with two of those risk factors, if you've had heart disease, if you've had a stroke, if you're on dialysis, if you've had a family history of peripheral arterial disease, if you're a nicotine user. So here's another tidbit. Whenever we see research studies, right, what does everyone say? Well, do you smoke, ma'am? Do you smoke? Well, one thing you realize in rural America, most people don't smoke. You know what they do? They chew tobacco, right? So nicotine is nicotine. And so you see their disease and you're like, wait, you told me you don't smoke. Well, do we know what the feedback is? Well, you didn't ask me if I chew tobacco. And some have been chewing since they were young, since they were 8, 9, 10. So that competency to understand how to ask the questions beyond what we're taught in the medical classrooms. Okay, because I wasn't taught that in the medical classroom. And then, lastly is patients who are obese or patients who have lupus and inflammatory disorders. Let's just go and touch their feet. That's the first thing we can do. Two, let's try and understand when we prescribe medicines, let's explain it to the patient, explain why it's important for them to address their risk factors. Your blood pressure has to be controlled, less than 130/80. I want your hemoglobin A1C, which is basically a protein that has a sugar coating on it and tells me how well your sugar has been controlled for months versus your fasting, right? Because everyone wants to just throw a number of their fasting. Well, what's your A1C? If it's your fasting is 92 today and then your A1C is 11.4, we have a problem. Right? So it's teaching them that is a passport. You have to understand what that is. Understand what your daily weights are. Understand what your, your diet. Your diet is important. One of the most preventable causes of death is your diet and exercise. And then screening, letting them know that you're available. Have your nurses trained, your techs trained, right? Phone numbers being given out to these patients are important. Why? They end up in the ancillary or secondary hospital. The first thing they'll do is call you. Dr. Fakorede, I'm here. I have, and then it facilitates care-seeking behavior because they start calling you for other things not related to the heart. I have pneumonia. What do I do, doc? Well, you try and get them to the right place, and you use other hats to get them to the right specialist. And so that is the most rewarding component, is because you've engendered their trust and it facilitates care-seeking behavior. And just have a good team around you, a good team that really cares and treats every patient like a family member, and you'll be good.
I have two more questions from the audience. Sure. We have time.
Sure, absolutely.
Okay. So we have one. So someone asked, I've heard stories of Grady, that's our big hospital here in Atlanta. Mm-hmm. I've heard stories of Grady medical patients hospitalized for osteomyelitis being consented for amputations, only to later learn that the patient did not consent to the procedure at all. While it's possible that the patient changed their mind overnight, how can we improve the process of obtaining consent so that our patients are truly informed?
That's a great, and that is why in every one of my rooms, I have this, it's behind me right now, but I think the light, it's a visual where we explain basically what I just showed you in terms of a model of what plaque looks like. And we explain every procedure. And then what I do is that there's a family member I have to talk to before I work on any patient. It's not just the patient. I have to speak to the person who either brings you in for that procedure or who's going to pick you up. Why? There has to be a knowledge, kind of there's a deficit when it comes to understanding but also informed consent. Do they really understand what the risks and benefits of this procedure? What is the procedure? So my nurses, when on intake, will repeat, hey, ma'am, did Dr. Fakorede explain this to you? If not, here's what it is again. Let's go over it. And then when they get on the table, my techs will ask them, do you know why you're here? Before we start sedating them. And so that it's a three-pronged approach. One. Two, a lot of these patients, have questions, but are scared of the white coat, right? It's this whole phenomenon that, hey, whatever the doctor says, how dare I question your years of medical training or question you, because it's this power, this authority that we stand over them. And so for me, anyone who's seen me in most of my talks, I come in just like a regular guy and just, speak to my patient. They're very comfortable. I keep it real with them. We say, we keep it 100. It's definitely whatever you want. Yeah, whatever questions you have. And, it's just alleviating that concern and treating them as a family member, not as a disease or as a number. And if it's osteomyelitis they have, or if there's a wound they have, you have to give that wound time to heal if it's an infection, but you have to restore circulation so that antibiotics can get to that wound to heal. So they need great wound care. So it's not just a quality, quote unquote, plumber or interventionalist you need. You need someone to give other facets, a good nutritionist to teach them that your nutritional level and your protein level and albumin levels are important for that to heal. You have to make sure that your wound care, physical therapy is important. Your dressings, your overall blood pressure and other risk factors. So it's a team approach, but also it's how much you invest and time investing in explaining every facet, not only to that patient, but to other family members as well. And letting them know that there's something called a second opinion. It's okay to question a doctor or seek a second opinion. I'm a big advocate of that.
Thanks. And our last question of the night is that, so you said that USPSTF assigned an I to the screening recommendation
Right.
for peripheral artery disease because they didn't have the data. So are they now collecting the data to change this grading?
You know, it's funny that they're saying there's no data, but I showed you basically 10 top papers, and you know, it's not, they've misread the data. And I think, you know, the same data that shows us that it's beneficial to screen for AAA's, abdominal aneurysms, that same population and that same data set was used to prove that PED screening is beneficial. But they stopped at, okay, yes, we're going to approve for screening for AAA's, but not for PED. None of those folks in that room, by the way, you know, it's an independent body. They look at research data, but none of them are true endovascular specialists that perform these procedures every day. So that is a problem. When you're writing policies, you need people in the room who actually are, you know, very knowledgeable about that topic. And so that is something that's missing. And so it's going to take decades to catch up to data, because of all cardiovascular trials that are performed to date, only less than 5% have included African Americans, less than 1% Hispanic. And look at what they represent in the population. So do you know how much time it's going to take to catch up and give them the data? That's decades. Do you know how many amputations can occur in decades if 200,000 occur every year, 130,000 of whom are diabetics? We have no time. It's all here and now. We want all of it here. We want it now. And you know, it's time for everyone to join us in this in bringing, you know, some justice to this topic.
Thank you. And thank you to you and all the audience members who stayed a little bit past time. That was such an excellent talk. So happy that you all got to join us and learn a little bit more about this topic and kind of open our eyes to just a very sad and scary, you know, epidemic that's happening in Mississippi. So with that, thanks everybody. I wish you a good night. Thanks, Dr. Fakorede.
God bless you all, and be great and be the change that we need in medicine. All right. God bless.
Thanks.
Thank you.